Good day, everyone. This is Jonathan Chen coming for you from the Stanford Center for Biomedical Informatics Research and the Division of Hospital Medicine. I'll be discussing with you the potential of discovering and distributing the latent knowledge embedded in clinical data. Here are some of my disclosures. And the overall learning objectives we'll be going about are distinguishing and demystifying certain buzzwords, understanding how machine learning technologies really relate to risk prediction, how you might evaluate these in the same type of terms that you think of laboratory diagnostic measures, as well as approaches to describe low yield versus high value diagnostic approaches. Why are we here? What is it that everyone's so interested in? Let me tell you what I think it is that there's a growing collective anticipation over the potential of emerging technologies which are demonstrating the capability for computers to answer questions previously thought to be impossible. Questions like, is that a picture of a chihuahua or a blueberry muffin? Kitten or a caramel ice cream? Dog or bagel? My personal favorite, parrot or guacamole? By now, we have technology that can automatically label every cat video on the internet and fill your social media feed with a perfect clickbait that will keep you distracted for hours, all while siphoning off your personal information, perhaps without you even realizing it. It does get you thinking, though, perhaps there could be a slightly more meaningful application of such technologies. How about, say, for example, is that a normal healthy lung or is that infected pneumonia? Is that normal lymph node tissue, or is that a metastatic cancer? More and more, you're just going to see examples like these where algorithms computationally can automatically answer questions with superhuman levels of accuracy, and yet medicine, healthcare, historically lags behind other industries by over a decade in terms of our effective adoption of information technology and use of real-world data. Even though you would think, shouldn't medicine, healthcare, the place where literally lives hang in the balance, be the place where we should be doing this the best? Consider, for example, that by some estimates, medical error is the third leading contributor to death in America, 250,000 dead per year. Now, some would reasonably argue, oh, this number is totally flawed, the methodology doesn't make sense. Look at the prior studies, it's probably closer to 100,000, maybe 50,000. Well, so two things. Even if it were only 50,000, that's still a jumbo jet airliner full of patients being pushed over a cliff to their deaths every single day. And more so, what is even more concerning is precisely that we cannot tell you what this number is. Apparently, that is how much we care about reliably capturing and using our real-world data in healthcare. But I don't know. Maybe lives are too abstract. Well, then fine. Consider the money. By some estimates, up to a third of the $3 trillion we spend on healthcare every year is essentially waste, extra services and administration's prices that don't actually help any patients. Perhaps there's no wonder then that many are looking for emerging technologies, intelligent systems, some way that can help us make better use of our scarce healthcare resources so that we can do more good for more people. So that's some of the why, but most of our discussion today is going to be about the what. Like, what is it we're actually talking about? You like AI, artificial intelligence, you like machine learning, deep learning, big data, precision health, like cognitive, like what are we talking about? At this point, it is clear that what AI actually is, what it is a marketing buzzword is what it is. When I think back to my PhD in computer science over a decade ago, I assumed we were going to be talking about HAL 9000, Jarvis from Iron Man, or David from Prometheus, right? Thinking machines that can reason through complex problems, adapt to new situations, and fluidly interact with human beings. We are nowhere close to such technology. So what is it we're talking about then? If we go with a much simpler definition, well, AI, that's just kind of any time a computer can mimic intelligent human behavior. Okay, but in that case, a good rules-based expert system from the 1980s is a perfectly good example of AI. Here, I got a rule for you here. If a patient has a fever and low blood pressure, I predict they'll have sepsis, a bad infection. Perfectly reasonable rule. You have a computer execute that, and that's a very standard basic form of artificial intelligence right there. Not usually what people are thinking about or talking about today. When someone is selling you AI nowadays, almost always what they're actually selling you is machine learning, which is really just a set of tools and techniques to automatically organize and learn from data, which in turn, a deep learning is just another particular subset of those tools, particularly effective in recent years at certain types of tasks like image recognition and language translation. The underlying common thread of machine learning is that, in contrast to the classical way you can imagine programming a computer from the top down with rules and how things work, instead, these are algorithms that learn by example. They learn by data, right? Is this I got 100 patients here with sepsis, and I got 100 patients here who don't. What's the difference? Is it their fever? Is it their lactate? Is it their procalcitonin? I mean, I don't know. You're a computer. You just look at these examples and you tell me. You tell me what makes them different, and so we can identify such cases in the future. If you break it down further, there are a wide range of techniques and possible applications for machine learning. But again, when you're being sold machine learning, the vast majority of the time is actually usually quite narrow. You're usually being sold a supervised learning classifier. Right? These are not thinking machines. These are models designed to answer very narrow multiple choice questions. Right? Look, is this a picture of a cat or is it a picture of a tumor? Right? Is my patient's going to have a stroke within the next year or are they not? Multiple choice question, often framed as, can you predict which one of these results is most likely going to occur? So let's break down a concrete example to think about how some of this might be used. Imagine someone's not feeling very well, they're a little bit short of breath, maybe some chest pain. They show up in our emergency room and we are concerned about it. I examine them, I meet them, order a CT scan, and I find, oh shoot, pulmonary embolism, blood clot in their lungs, very dangerous situation. But it's okay, I'm going to get them on the appropriate medication, I'm going to get them on some anticoagulants. But now there's actually a very important question I have to answer to make an important decision. Is this patient going to be okay? Because I need to make a decision to decide whether or not to admit them to the hospital. So how would I do that? How would any of us do that? I mean, of course, you would go see the patient, you would talk to them, see what their symptoms are, you would examine them, with these healer's hands, I would lay it on them and make my assessment. You know what? This patient's actually fine. It's okay. Just take the medicine, go home, everything will be okay. You can trust me, I'm a doctor. Now, as much as I like to joke about that, the reality is expert intuition is extremely powerful and can be quite effective. The challenge with it is that it is extremely difficult to reproduce, which means that it is essentially impossible to deliver it at scale with consistency without some kind of support system. Support, say, like, how about let's use some data. In this mocked-up example, every dot here represents some patient who had a pulmonary embolism before. The blue dots were patients who they got appropriate treatment and everything went fine, they got better. Red dots are those patients where something bad happened. Maybe they ended up on a ventilator in the ICU, or maybe they just died. The question is then, what would you do then if Mr. Green showed up in your hospital? Of course, you're going to do your assessment. You're going to make your best prediction of what's probably going to happen to this person, so you make an appropriate triage decision. Or what else could we do to drive our call on how to make the best treatment decision? Let's use our data, right? Let's draw a line, a decision boundary through our cases in a mathematically optimal way that puts as many blue patients on one side and red patients on the other. If we can do that, now we can quantitatively support what we are already intuiting, that Mr. Green looks a lot more like a blue patient than a red patient, and we can make our support call in making risk assessments based on our best predictions of a future outcome. Now what you're showing here is actually a battery of different approaches. In the top left are a set of different input example data, red and blue patients. And here are a battery of different machine learning algorithms, all trying to figure out how to separate the world into red and blue spaces. The broader point to think about here is that these are all standard algorithms at this point, been in use for many applications for decades. Open source software, anyone can download and start to use these types of tools now. And combine that with the increasing ubiquity of electronic health data, and perhaps now the time is right to start developing and deploying such data-driven machine learning applications in healthcare. And yet, if you think about it, the concept of applying risk prediction models in medicine is really not a new concept. Here's a calculator for risk prediction off a popular website based on historical cohort data. And for many different medical applications, should you admit this patient to the hospital? Should you give them a blood thinner? Should you give them cholesterol medicine? All historical concepts that have been well used for decades. Look outside of medicine. These types of algorithms are pervasive in our everyday life, right? From filtering out your email spam to your FICO credit score, predicting whether or not you're going to repay your loans or not. What's just become a lot more popular in recent years are automated scores, right? This website-based calculator, very powerful and effective already, but I got to open up a web page, I got to data entry in these numbers. What if instead, with our electronic medical record infrastructure, as clunky as it exists, as long as it does exist, let's just monitor all of our patients 24 hours a day based on 100 pieces of information for each one rather than just what we can data entry one at a time. That now makes it possible and feasible to approach in a way which in prior years just wasn't possible given the infrastructure available. Before we get too carried away though, realize there's a distinction between the classical kinds of observational research you're used to hearing about and machine learning or prediction model based work, right? Classical research about, does smoking cause cancer, right? Those are based on trying to explain something about how the world works. These types of prediction models, they don't know and they don't care how or why anything works. They are only trying to optimize prediction accuracy, which is something different, right? How do you know that smoking causes cancer, right? We've never run the randomized control trial, so in some sense we don't really know. But what we do know is that the observational evidence is overwhelming. If you look at prior cohorts of some patients who smoked and some who didn't, you follow them over time, you adjust for as many confounding factors as you can find, and still it looks like there's an independently associated risk factor for that outcome, which is powerful, shareable knowledge, right? I read that paper, oh, I'm going to tell all my patients stop smoking. Compare that. Somebody publishes an algorithm that you could take a picture of a mole and it tells you if it's cancer or not. That's amazing. And I'm going to see 10 patients in clinic tomorrow, and having read that paper does nothing for me, right? We have no really infrastructure to feasibly quickly exchange these types of modules with each other. Also be aware is that since these algorithms are only trying to predict accuracy, that means they can also learn strange things. They could learn that, say, hey, patients visited by palliative care are very likely to die. Which is true. This statement is absolutely true, but please don't conclude, oh great, all we have to do is just fire palliative care in the chaplain and that will reduce patient deaths. I mean, no, obviously that is not correct. You get why this doesn't make sense because there's confounding by indication. The kind of patients palliative care was going to see were the kind of patients who probably weren't going to do well. But the hardest thing to train a computer is common sense. It has no conception of this context. And so it doesn't get why you realize making such a prediction doesn't even make sense because there's nothing you could do about that in these cases. But these types of algorithms, they're only trying to optimize accuracy because that's the only thing we told them to do. So just don't be surprised when this happens and just make sure you're applying them in a way that makes sense for effective healthcare. Thinking more broadly, again, a battery of different techniques that are available. I'm actually particularly interested in unsupervised learning techniques. And why is that? There's some argument for the unreasonable effectiveness of data. This is particularly true for medical data where it's very hard or very expensive to get labeled training data, right? If I want to know if there's a picture of a tumor in this scan, I mean, you got to hire a bunch of pathologists, right? And to manually look through thousands of images and annotate them with what they think is the case there. That's doable, but that gets very laborious and very quickly becomes difficult to scale that to the level that's needed to adequately train these algorithms. And so we can lament, oh, imagine all the cool things I could do if only I had this lovingly curated data set. Or what can we consider, what can we do with the masses of unlabeled training data that are already available? This is indeed how many companies have used this type of approaches and data to enhance their commerce. For example, a classic story, a supermarket ran this data on their club cards, keeping track of what you buy over time, and find that people buy beer and diapers a lot more than you would expect by random chance. Now you can apply then a theory to that data. Well, all these beleaguered parents having to come out and grab some more diapers, hey, I might as well grab some beer while I'm here. And then you can imagine making a strategic decision as the market manager. Why don't we put all the diapers in the back of the store and we'll stack a really expensive alcohol next to it to encourage some impulse buys? Coming back to medicine, though, I try to take that concept and bring it towards clinical orders, clinical decision making. What we see here are some screenshots from a prototype I developed on ways that might mimic an electronic medical record interface as a doctor's trying to put in orders, right? The concrete medication, laboratory tests, imaging orders to actually execute patient care. And what's happening here is a list of suggestions the computer is making even as I'm working. In this case, knowing nothing about the patient, these suggestions are just the top 10 most common things that are ordered in our hospital overall. Let's say, what if I did a manual search for a CBC? Here we go. Here's all the laboratory tests that start with CBC, a complete blood count, and indeed I'm going to order a complete blood count with differential and a slide review. Added that to my shopping cart, as it were, in the top left. Now what you'll see is this list in the middle here. These are the clinical orders that are most likely to occur within the next 24 hours based on what other doctors have similarly done. On the right, these are the clinical orders that are disproportionately likely to occur within the next 24 hours, such as an LDH or reticulocyte. Oh, actually a reticulocyte count. That's a good one. I'm working up my patient for anemia, basically. And indeed, now with these two pieces of information in my shopping cart, the system juggles its list of suggestions. And then on the right, you'll see suggestions like, oh, a ferritin, transferrin, haploid. Yeah, that's right. It realizes I'm working up anemia. It's trying to find other things related to that based on the prior behavior. So here are haptoglobin. Great. Now maybe it really looks like I'm looking for a hemolytic anemia. LDH, direct Coombs are starting to rise to the top as the system starts to synthesize that information. So a few things to point out here. You'll notice at no time did I ever type in the words, let alone pick the ICD-10 diagnosis code for anemia or hemolysis or something like this. I'm just taking care of the patient, right? I'm just punching in the clinical orders, the thing I was going to do anyway. And what's happening here is that the system should be designed well enough that it can observe what we're doing and anticipate what we need without us even explicitly having to ask for it. Further considerations, how did I make this, right? Did I studiously read all the medical textbooks and figure out a bunch of rules about how to work up anemia and hemolysis? I mean, I could have done that, but I didn't because that's actually very brittle. It's a very unstable way because medicine changes so much over time. You know, maybe I hired 100 doctors to annotate 10,000 patient charts. Hey, for this patient with anemia, what would you order next? What would be the next medication? What would be the next diagnostic test? Could have done that, but also I didn't because I can't afford to do that. That's a very expensive and laborious process. But then I considered, well, you know what? What are we as clinicians every day? We're essentially an army of manual annotators working all the time. We review our patient's case and history, get the best information we can, and then we annotate the chart with our orders. That is the most concrete representation of what our best guess is for the treatment of our patients and diagnostic processes. So hopefully that seems like a compelling concept, but if you've thought hard enough about it, it's also worth asking, wait a second. You know, is this the wisdom of the crowd or is this the tyranny of the mob? Right? Just because something is popular, that does not mean that it is good. This is extremely difficult to unpack in medicine because there is no gold standard to define what are good medical decisions. If you want to unpack more of it, I have a whole slew of research papers all about unpacking this very complex concept, but I'll walk through a very simple anecdotal example to walk through conceptually why this surprisingly may even work. So you may remember a classic TV game show, Who Wants to Be a Millionaire? You can answer a multiple choice question for big money. But the real classic thing about the show was that if you get stuck on a question, you have lifelines. You can ask for help. So what can you do? You can phone a friend. What is that? You can call anybody in the world you want. Who would you call? I would call the smartest, most knowledgeable person I know, the person who I believe has the best chance of giving me the correct answer. I would consult a specialist. Alternatively, you can also just ask the audience. These aren't knowledgeable experts. There's a bunch of people watching a TV game show in the studio audience. So how well do you think these two approaches work? It turns out that if you phone a friend, if you ask an expert, so to speak, they're right 65% of the time. Way better than random. They definitely are helping you if you're stuck. What's interesting is that if you ask the audience ends up being right over 91% of the time. Like, what on earth is going on here? Now, to clarify, this does not mean that 91% of the audience are geniuses and they knew the answer that you didn't. In this case, only 55% picked the correct answer. What this is describing is that majority vote answer turns out to be correct more than 90% of the time. It's not perfect, but it's way better than random and often as good or better than asking an individual expert. If you think about this, this is just a TV game show, right? But there's actually mathematical underpinnings for this. Theorems from 200 years ago. It's the reason why we have juries rather than judges decide our fate. It's the reason we prefer voting democracies rather than dictatorships making decisions. It's the difference is, I mean, you think one juror, one voter, but they could be wrong. They might have incorrect information or make bad calls. Shouldn't one smart judge be better? Maybe, but as long as your individual voters, your individual jurors are at least better than random, aggregating the majority vote of a larger and larger group increases substantially your chances of converging on the correct answer. And indeed, this is the same principle behind the way many machine learning processes work, ensemble learning. If a way to create strong classifiers by aggregating the votes of many weak classifiers. Another trade-off you might consider, though, when thinking about this recommender system I had developed, was that, Amazon recommends you a product. They just want you to buy more stuff. That's not really what we're trying to do in medicine. So could there be an issue where giving suggestions to a physician might just make them spend more money ineffectively, right? Order more tests and procedures and medications that aren't necessary. This really is an important dynamic to break down because there's this fundamental tension between quality, cost, and access in healthcare. All this drama over healthcare reform, you cannot fix all three of these things at the same time because fundamentally healthcare is a scarce resource. The scarcest resource of all is access to human expertise. Every time you try to help by pulling in one direction here, just be aware you probably broke something on the other side. Thinking about that, well, what can we do? Can we instead find ways to advance the efficient frontier, right? The only way to break out of that cycle and this dogfight over resources is, one, I'd like to optimistically think, can we create more supply through automation, which is a lot of what the type of AI tech research I'm trying to develop, as well as can you systematically find fraud, waste, and abuse and other inefficiencies that can ultimately improve everybody's outcomes. And indeed, over $200 billion per year of healthcare spending in the US is attributed to unnecessary tests and procedures, the highest volume of which is laboratory tests, with estimates up to a quarter to a half of inpatient tests are probably not necessary to actually help the patients in the context of their care. With that in mind, I tried to develop another concept of what if we could quantitatively estimate the pretest probability of any diagnostic test, and how could we use that? And really, this fits into a standard framework of the threshold approach to medical decision making. If this line from 0 to 100% represents the probability that some patient you think that they have a disease or diagnosis, should you order a test to figure out what to do with them? Well, if your probability is super low, very close to 0%, then no, you shouldn't do anything. It's so unlikely. You just don't bother doing anything. Just move on. By the same token, if your probability is so close to 100%, why would you test anything? Just act as if. Just start treatment on the patients. It's so likely that that's the case already. Why bother a test to do something to confirm something that you already knew? It's really only in this middle range of uncertainty where testing makes sense so that it can move your pre to a post-test probability that pushes you past either the threshold to test or the threshold to treat. We try to develop this concept here for our inpatient hospital. Here are the inpatient laboratory tests that are most commonly repeated at our hospital. For example, at the top, the basic metabolic panel. Everybody gets that at some point. The total bar represents the total volume of that laboratory test order. The dark black bar part represents what fraction of those were a repeat of the exact same test within 24 hours of the last time it was ordered. And now you might argue, well, I mean, a metabolic panel, my patient's getting actively diuresed, and so maybe I need to watch their metabolic panel multiple times per day. That could be the case, but how about a complete blood count with a differential, a phosphorus level? Are those things that need to be checked multiple times a day? It's pretty hard to argue that that's the case in the majority of cases. If you look at guidelines, you can find other called out examples. Patients getting their albumin checked or their hemoglobin A1C rechecked, sometimes within a week, sometimes within 24 hours. I mean, these are just mistakes, right? There's really no physiologically plausible way where the value of that test could even change that rapidly. And so ultimately, clearly just represents an inefficient way that these diagnostic testing are being done and repeatedly done. To break down the trend relative repetitions further, here are several common laboratory tests. We'll look at the purple one, for example, a patient's hemoglobin. How often does it yield a normal result if there were 0 prior repeats? Then 10% chance, 15% chance it yields a normal result. Hey, that means it's very likely to be abnormal. You should probably order that test for most patients coming to the hospital. However, if you look over time, if there have been 1, 2, 3, 4, 5 repeatedly normal values for the patient's hemoglobin in the past week, it's no longer 10% chance of being normal next. It's going very rapidly converge towards greater than 80, 90+% chance that this test is going to still be normal the 6th, 7th time you order it, suggesting, again, a very diminishing returns on the value of repeated diagnostic testing. Those prior examples were just to illustrate in a simple way about in terms of repetition, how it becomes very predictable and diminishing value, low information gain from repeated testing. However, there are other ways that test results could be predictable even if you haven't even done them yet. And in this case, what I'm going to try to do is let's just pour all the electronic medical data we have into machine learning predictive models to see if it's possible to predict the results of many common laboratory tests even before you even order them, based on data that's already available about the patient up to that time. Having done a battery of those, indeed, here's a receiver operating characteristic curve for many common laboratory test components. Indeed, it's actually quite possible to make very accurate predictions about some of these results. The balance here being, if you show this to a typical clinician, they have no idea what they're looking at. A ROC curve, like that just doesn't make sense to them, like how to apply that. So what you need to do is think further about how do you break that down into certain decision processes that they can consider. What we're showing in the graph A here is the x-axis is the score, the risk probability that a prediction model guesses that a test will yield an abnormal result or not. And the light gray represents the histogram for all of the tests that actually did yield a positive result, versus on the darker gray on the left is all the tests that didn't yield a positive result. They were negative. And this is what you want to see. You want to see the two distributions squished as far to the side as possible. It means the prediction model has good discrimination. It does a good job of telling the difference between positive and negative cases. By default, however, many approaches will just cut this down the middle, make a decision boundary right in half and say, well, anything above 50% chance, we'll call it positive. Anything below, we'll call it negative. But that is actually almost always wrong in medicine, because medicine is plagued by things that are maybe not common, but are very bad if they happen. The impact of a false positive is often not as the same impact as a false negative. So here, what if instead we can customize this dashed line where we want to put our decision boundary? So everything above, we're calling a positive, sometimes mostly right, sometimes wrong. Everything below, we're going to call it negative, mostly right, sometimes wrong. But doing it in a way that we optimize, in this case, our negative predictive value, and by picking a particular point on the ROC curve. If we do that, aiming for a negative predictive value of 95%, here are the results for a battery of the most common laboratory tests ordered repetitively in the hospital. For example, the top, magnesium, the total length of the bar represents the total value of how often. This is a very commonly ordered and reordered test in our hospital. Everything to the left of the midline are cases where our algorithm would have predicted, I think this test is going to end up yielding an abnormal result, in which case, basically, we're not going to say anything. If it's going to be abnormal, you should probably check the test and do something about it. On the right, though, are all the volume of tests where we would have predicted the test is probably just going to yield a normal result. And green represents all the cases. Indeed, we were right. The red sliver is how often we are wrong. But that extreme ratio suggests there's probably a lot of this testing and retesting being done that very predictably is not going to give you unexpected information. The test is just going to be normal anyway, and it suggests there's a substantial opportunity to reduce the inefficient use of these diagnostic testing processes. Just to reinforce though, low information does not equal low importance. Particularly in medicine, there are often cases where very unlikely events are catastrophically bad if you miss them. Well, with that line of thinking though, does that mean, well, it never hurts to get more information, so let's just do more tests just in case, right? It never hurts to get more information. Well, consider, for example, if you're drawing blood cultures on a patient, right? You're worried they have a bacterial bloodstream infection. That's really bad. You certainly wouldn't want to miss that. And that is true. So in fact, the standard of care, consider that you actually don't really care whether a blood culture result is positive or negative. What you care about is, does your patient have a bloodstream infection? And so the standard of care is to not order one blood culture bottle, you order a set of 4 blood culture bottles, because each one is imperfectly sensitive. It's imperfectly correlated with the thing you actually care about. Does your patient have an infection? So we draw 4 bottles to increase our sensitivity, because we really want to be sure. We would hate to miss that unlikely but really bad event. Okay, but here's a thought for you. Why don't we order 5 blood culture bottles? Why don't we order 6, 12 blood culture bottles? In fact, if someone had infectious endocarditis, you're wondering if that's the case, you would order 12 blood culture bottles. That would be the standard of care. But why stop there? Why not order 50 blood culture bottles, right? You can never hurt to have more information. You really got to be sure. But the reason you don't, I would argue in the general framework of how you think here, is that the 50th blood culture bottle, the results of that is going to be so predictable based on the prior 49 blood culture bottles that it makes it just not worth it anymore. Even though there is a non-zero probability that 50th blood culture bottle will give you new information, it becomes so unlikely, there's so much diminishing returns because of the predictability of the results that at some point it is no longer worth it to do so. And the broad framework I'm thinking through is there are other ways to make diagnostic testing processes predictable even without just repetition, through using other contextual information readily available about the patient through existing electronic medical records. Ultimately, putting all that together, I would consider just the past few years where we have been on the hype cycle for emerging technology. The x-axis here is time, y-axis is expectations, it's hype, how excited we are for new things. I wrote a perspective a few years ago commenting that I noticed what was at the tip top of the peak of inflated expectations a few years ago. It's deep learning, machine learning, so-called AI technologies. And this got me worried because I know what happens next. We're going to crash into the trough of disillusionment. You can see blockchain was already headed down. The thing is, people are going to have over expectations and they're going to be disappointed. I mean, I thought 80% of doctors would be replaced by computers. I thought all of these algorithms will replace pathologists and radiologists by now. I'm not sure those were the right expectations to have, even though there is incredible potential for ways to improve our healthcare systems using these types of approaches. What I'm ultimately hoping for is that the kinds of discussions we're having today about the potential, the limitations, and the implications of such technology will allow us to soften that crash into the trough of disillusionment so that we can quickly move on to the slope of enlightenment, where we effectively use every information data source to best improve our collective health. So what does that mean? Do I think that computers are going to be smarter than humans? Or no, I think humans are fundamentally always smarter than computers? A very interesting question to discuss, but ultimately I also think it doesn't matter. It's irrelevant. It's the wrong question to ask. Because the answer is, let's combine the best data-driven machine learning software with the best human clinical hardware, and together we can most effectively deliver better care combined than either of us could alone. Thank you.